Yong, Professor of Orthopedic Surgery, Beijing Shaoyong Hospital, Capital University of China. He will speak about rigid scoliosis and correction of rigid scoliosis. Professor Yong, you are with us, sir.
Thank you,
Yes.
Professor Lashkop, and thank
you
all
so
the
much,
professors.
sir.
And it's very nice to see you all. And it's my great honor to join this webinar to share our experiences on the treatment of severe rigid kyphoscoliosis. I'm from Beijing, China, and our hospital was department was established in 1978. And until now, we are from the 30 beds department. Now we have 5 wards, more than 200 beds, and with almost 200 staff and doctors and nurses in our department. We are the AOSPAN Asia Pacific Surgeon Training Center, also the key department in orthopedic surgery in Beijing. So this is my spine team. We have 12 attendings. It's one of the top spinal deformity center in mainland China. We perform more than 200 spinal deformity surgeries annually. We know for the scoliosis and the kyphosis more than 90 degree, flexibility less than 30%. We call the severe and the rigid deformity. And for those, correction are real challenge for us, not only in China, but in all over the world. And the challenges in China is because those large and rigid curve, it has a very complex deformity. And also the patient normally has a poor physical condition. And the primary function always, most of the time, are compromised. And also, China is a very large country. There are some area, especially in the remote area, they have a poor financial condition and the lack of financial support. So for those severe rigid deformity population, we have a team we call the Dr. Hai Spine Rescue Mission Team. We work with varieties of charity organizations, and we travel to all over the China. We find the patients and brought them to our hospital. We're using a comprehensive traction protocol, and we're also utilizing different osteotomy technique to this organization work we has been working on for more than 14 years now. And we're screening the school in the remote area, in the Tibet and very remote area. We educate the local medical personnel so they can find the deformity patient. We also evaluate those patients to do the surgical planning and determine the budget. For the last 14 years, we have treated those cases, more than 500 cases. And the funding is from some donation from charity and donation of the implants, and also waive for the partial hospital fees. Those are the photos we're going to different places to have screening and find out those patients. And for last 2 years, I also brought my son to go with me to the Tibet print. For those patients, we do have a preoperative traction protocol. All patients with severe and rigid kyphoscoliosis will underwent a pre-op traction. First, we're utilizing the skin traction for 1 or 2 weeks. And then if the curve change less than 10%, we will give patient to have either halo gravity traction or halo pelvis traction or halo femoral traction. Once the patient meets the surgical requirement, we will perform the surgery for the patient. And the traction is can achieve some soft tissue release is release of the compensate curve, not the main curve. Sometimes the main curve is very rigid. We cannot release anymore. And also by traction, we can evaluate the patient's neurologic reaction to see if there's any neurologic deterioration of the traction. So in order, we can minimize the neurologic complications for the patients. And this is the traction of a skin traction. Every patient are very easy. They lay on the bed, we use a chain traction on the head, and then we use a leg traction for the later. And this is in-hospital traction. Every time we track the patient for 3 to 60 minutes, 3 to 5 times per day, and then use a weight of 1/5 or 1/3 of the whole body weight. It depends on how the tolerance of the patient they are experiencing. And this is a 10 years old early onset scoliosis. We see that the curve is 129-degree scoliosis. And after 10 days traction, the curve changed to 76. It's quite a significant change of that. And you look at the lateral, it's from 130 degree to 90 degree. And we perform a growing rod technique surgery for the patients. It had a pretty satisfied result. For those patients with old age, very rigid curve, we use hollow gravity traction. Those patients, they are stay in the community hospital, not our main hospital. They are doing the daytime traction with the weight of highest is half of the body weight, the traction for 1 to 3 months. By traction, we can improve the pulmonary function, also evaluate the neurologic reaction after the correction. You see this patient is a 21 years female, congenital scoliosis with a split anterior cord. She underwent a hallogravity traction for 1 month, and we perform a one-time posterior procedure. And the scoliosis is correct to 70%, and the kyphosis is 50% without any neurologic incidents. And this another patient, very severe. It's 23 years old, and it's more than almost 190 degree of curve. Hallogravity traction for 2 months. After traction, the surgery was done satisfactorily without any major complications. Hallopelvis traction probably is the one of the most powerful traction with the daily life limitations significant, because once the patient had on the hallogravity traction, it will cause the patient difficult on sleeping. So it also has very high complications in the pain, but the effect on pulmonary function improvement, also physical condition improvement, curve flexibility are very significant. So you look at this 27 years old patient, in the traction for 3 months, the curve improved more than 30%, and there's no occurrence of neurologic incidents. The initial speed for traction is 3 to 50 millimeter per day. And later on, it's 2 millimeter per day for the traction. So this is the patient had a previous surgery, traction for 2 months, and then the final surgery. Significant improvement of the curve. The halofemoral traction probably is the most powerful traction, but it has daily life limitation because the patient has to lie in the bed. You have to put the pin on the head, also on the femur, but it has very good traction. So this patient is a 21 years old female, congenital scoliosis and a kyphosis, more than 150 degree. We did the traction for 2 months. You see the curve correct beautifully. When you're doing a deformity correction, you are utilizing all the correction maneuver, all the techniques, basic from distraction, compression, county level, and the translation. Inside to bending, but the most powerful maneuver is the osteotomy. The spinal osteotomy, it can mobilize the rigid spine. You can adequate release of the rigid spine. According to anatomic classification by Dr. Schwab, is 6th grade osteotomy. But in our experience, the most used osteo method is the grade 2 or grade 5, 6. So it used to be called SPO or pontiectomy. It developed by Smith-Peterson in 1945 and then modified by Ponti in 1984. Our team has published as initial technique to utilize for adult spinal deformity in 2008. This pontiectomy, or now we call the posterior column osteotomy, is using for the large curve. It can achieve correction in the upthoracic for 30.6 degree per level, in the middle thoracic 7.2 degree, in the thoracic lumbar is more than 10 degree, and the lumbar region is almost 10 degrees. So average overall correction per level is about 8 degrees. Another technique is the posterior body column resection, developed by Professor Suk from Korea in 2002. It has wide complications in the world, including congenital scoliosis, kyphosis, degenerative scoliosis. It is a very challenging technique with a great risk. Our team reports the technique in the severe rigid scoliosis in 2006. This is the first report in China. This is our case. From 2006 to 2018, in the 12 years when I joined the Cullen Hospital, we had a spinal deformity case, 2,300 plus cases. Among them, more than 90 degrees, the flexibility less than 30 degrees is 11%, 253 cases. The surgical solution for those patients, we underwent the preoperative traction. We also using the osteotomy technique, the pontiectomy, asymmetric multiple level pontiectomy, and the PCO plus PSO, pedicle subtraction osteotomy, and the posterior vertebral column resection. You see the cases is 95 cases for PCO and 119 cases for grade 4 to grade 6 osteotomy. The pontiectomy, you are taking out the spinal process. You do a complete facetectomy and a wide inferior and a superior laminectomy. You take out the entire ligament foramen, and also you compress or distraction performed on the narrowed gap, is showing in the photo. Please remember, the more facet joint or the more ligament take out, give you more ability to have the correction. So when you do the procedure, you need to pay attention to identification of pedicle and the protected nerve roots. The resection width is 7 to 10 millimeter. It will achieve 7 to 10 degree per level. The convex side is wider than the concave side. To enhance the correction, make sure to do the facetectomy pedicle to pedicle. You see pedicle to pedicle, then you have a maximum correction of the each level. This is the image we call the multiple level asymmetric pontiectomy. You have more correction on this side, less osteotomy on this side. When you correct, you will have a very good correction. For the ponti or post column osteotomy, it indicates for a long, gradual, rounded scoliosis and kyphosis. A rigid curve will be better. You can combine with other type of osteotomy. The immobilized disc space is a prerequisite for puncting. It's a must. Once the level is not fixed, the posterior column osteotomy will work. Our technique and the series has published in the spine and also the World Neurospine Surgery in 2019. Let's have some cases. This is a 21 years of female. It's an adult idiopathic scoliosis. The large curve is more than 150 degree. It has only a flexibility less than 20%. The main curve is only 18% of flexibility. You see the CT scan, it's a large curve with severe trunk deformity. We did a holographic traction for 2 months. It changed from 157 degree to 114 degree, and changed 28% of flexibility. This is an intraoperative image showing that we did the 7 level of asymmetric Ponti osteotomy, and this is after the osteotomy. This is a temporary rod insertion to protect the unstable spinal column. Because the rib cage is severe deformed, before the correction, we take out some ribs. We did the thoracoplasty. So this is the final correction. You see from 158 degree to 59 degree. It has more than 60% of correction, and the patient height was increased 15 centimeters. Another case is a 29 years old male patient. The trunk collapse is significant. It has a very large curves. You see the curve, 133 degree in scoliosis and 106 degree in kyphosis. And this is intraoperative X-ray. Multiple level Ponti osteotomy plus at the apex we did the pedicle subtraction osteotomy. So it's combined with the Ponti osteotomy and also the PSO. So this is the correction from 133 to 37. It's 72% of correction in scoliosis and 70% in kyphosis. This is the 15 years old, 17 patient, and it's a congenital scoliosis and also multiple level Ponti osteotomy, more than 60% of correction. And this is a 24 years old female patient from Tibet, and also multiple level change to quite significant correction. This is another 25 years old congenital scoliosis. The correction rate is about 50 degree. So multiple level Ponti osteotomy can also achieve satisfactory of the correction. And PCR, when you perform PCR, you will do apex at the deformity, and you will resect all the posterior structures. You did the fasciectomy at the apex level and entire vertebral body and adjacent disc above and below. So this is the image showing the surgery intraoperatively. The spinal cord is very fragile. When you do the correction, you need a temporary rod insertion to make sure the rod is stable. The osteocyte is stable, not to do any shifting or translation of the curve. Otherwise, it will cause neurological damage. So the posterior osteotomy vertebral column is take out all the spinal process and take out the posterior column. The screw insert should be as close as you can to the osteotomy site, so you can have a better control of the spinal column. Otherwise, there will be shifting either anterior posteriorly or either lateral translation, and then the problem will happen. And doing the 3-column section, another important thing is try to use another rod, 1 or 2, we call that satellite rod, to increase the stability of the osteotomy site to prevent any translation of the position. So this is a 23 years old congenital kyphoscoliosis, also from Tibet, and very large curve, trunk collapse. And the curve is more than 180 degrees. The spine is all collapsed together. And the primary function is not very good. There's almost no movement at the apex level. You see the CT scan, the spine look like this. We call the roller coaster deformity. It means like in the playground, in the roller coaster is from cervical, the spine is going down and twisted and up again, and then twisted going down again. You see the spine and the rib head are all collapsed together. And the problem with this kind of deformity is because the upthoracic and the cervical curve is large, and this direction make you very difficult to insert the screw. So for those kind of patients, the preoperative retraction are the must to do. So the CT scan, from one scan, you can see 2 spinal canal. And those kind of severe rigid deformity, you need a thorough preoperative radiographic evaluation, and to rule out there's any intraspinal deformity or abnormal, or you can find out what's going on for the vertebral body, how the pedicle, the direction, the width, and the depth. So will help you to do that. Also, with the modern technology of a 3D model, you can also understand the deformed anatomy structure, understand how the patient you will facing with you in the surgery. So this patient, we did a halogravity retraction for 3 months. And during that period, her primary function improved a lot. And the whole body condition was good. You see the traction, 2.5 months, 2.5 months. And the curve, especially the up curve, you look at the pre-traction curve, the head is here, the cervical spine is here, the thoracic curve is like this. So after traction, the cervical here, the curve is like this. So there's a possible to insert the screw and also to pre-bend the rod. Otherwise, the rod is too sensitive. So this is intraoperatively. And exposure and the temporary unilateral pedicle screw insertion plus a temporary rod insertion. And you put in the screw on another site. And once the site is put, you need a temporary rod. And then you do osteotomy. This osteotomy is 2.5 level, means 2 body and 3 disc. And after correction, use a satellite rod to increase the stability of the. I was trying to close the gap of this patient, but it was too difficult. When I close this, the neural monitoring has some signal changes. So I wait a while, make sure there's no direct compression at the osteocyte osteotomy site, and then I finished the procedure. So this is after surgery, from 180-degree correct to 70-degree and 97-degree. It looks much better, and you see that the body height was increased more than 10 centimeters. At her follow-up, for those rigid curve, the follow-up in 1 year and 2 years, we will do primary function tests. Most of the patients, they have improved respiratory function. This is another case. It's a 35-year-old female. He had surgical surgery back to 26 years before. And because the implant at that time was a Harrington rod plus Lucky subliminal wire, has dislodged the hook. So he took out the hook 20 years ago. And when he came, the curve was like this. And you see the curve, there's a very severe thoracic curve, the fused curve in middle, large, almost 140 degree of kyphosis. And the CT scan, we are showing the fused mass in the middle column, middle thoracic to the lumbar. And you see the thoracic curve is also very severe. And 3D reconstruction is mandatory for all the patients to understand the structure of the deformity, also to plan your screw insertion, the size, the direction, and so on. For some revision patients, you may need to do a template for the screw insertion at the apex region, because their fusion mass, the anatomical structure are out of order. You need to find out where to put the screw accurately, not causing any neurologic deficit. So this is a patient actually before and the surgery, main thoracic curve 135 degree, and the lumbar curve, because the severe 120 degree of the thoracic, it has a large lumbar lordosis. CT scan, you can see the fusion mass in the middle, and all the ribs are collapsed together and has very large rotation of the patient. So the CT scan showing the whole structure, and it's very significant of the wrist bed. We also did a traction for the halo gravity for 1 month, because we want to change the thoracic curve to a more flexible, and in order to get in the screw in position. So this is the intraoperative image, and you see the screw insertion, temporary rod, and a fusion mass. We take out the whole bony and soft tissue construction around the apex. There should be more than 3 levels of the, because now it's 35 degree, 35 years old. He had a surgery at the 26 years ago. That was 9 years old. So we take out all these. Look at, we have 2 temporary rods. And even though we are still free of the large gap in there, will causing any problem. Before you do any correction, doing the osteotomy, you need to do this side first, because you want to take out all the bone structure here. So the spinal cord will shifting towards the convex side, and less attention on the apex. So this is the whole structure, and the close of the gap for almost 70% of the gap. So this is the finals. The patient was changed significantly. The gap, we use a mesh cage to do the anterior support, and the curve from 135 degree to 67 degree. It's almost 50% correction. The thoracic kyphosis was had 38%. The patient height, actually it's the trunk collapse changed a lot. It increased 10 centimeters. It's very good for his primary function. So the patient has no neurologic deficits. Here's a lady patient. It's congenital kyphoscoliosis, 27 years old, is 138 centimeter high, weighs 40 kilogram. Look at actually, the patient is congenital kyphoscoliosis in the lumbar thoracic region. From the AP X-ray, you can see the spinal canal. That means those parts, spine is almost horizontal. It's 160 degree. This is CT scan. The CT scan showing that the congenital not developed is multiple congenital hemivertebra, insegmental vertebrae, and a very large curve during that period. And the CT scan, you can see this. This is very clear. And we also did a 3D model for this patient. This patient, we also have a halo gravity traction for 2 months. And finally, this is using surgery map to stimulate the correction. We try to do a vertebral column at the apex. So this is before and after. This is by simulation. Finally, we did the T7 to L4 with a 3-level grade 6 posterior vertebral column resection procedure. This is the intraoperative surgery. Exposure, temporary rod, and we put in 2 rods. And after the osteotomy, you see at this patient, we try to leave the spinal process intact, because by doing that, we can have some protection on the spinal cord. You see the spinal cord is totally free, 3-level, and the transfer, the spinal process, the after correction is getting more and more close. So this is the after correction. You see the curve change a lot. There's a 3-level vertebral resection, temporary rod. So this is an intraoperative surgery. This is X-ray. This is intraoperative after pedicle insertion. This is the after correction and the mesh cage insertion at the osteotomy site. And this is a 3D model we were using. You see a very clear see how the construct was going on, and after surgery, and the correction was significant. And the patient had a very good exercise. You know, the 3D construction before surgery, after surgery, and the CT scan, the mesh cage was put in well. The correction is quite significant. So the patient height increased 12 centimeter, and the scoliosis correction is 87%, and the kyphosis correct also 80%. This is a very good. You see that the girl was totally changed. The body shape was back to normal. She was very happy. This is just another cases of demonstration. 21 years old, idiopathic scoliosis from the kids, and the posterior ultimate correction correct to more than 50%. And for those 253 cases, a patient was underwent the procedure very well. The operating time is from almost 2.5 hours to 6 hours. And the blood loss, the higher in the severe case, some cases are 4,000, almost 5,000 millimeter. But also the mainly is about 1,000 to 2,000 meters. The correction rate is more than 50%. There's no death or other major complications. For those complications, the complications is the worrisome is the neurological incidence. We have 19 cases with a major in 8 cases, minor in 11 cases. The minor means decreased muscle power or sensation. The major means paralysis or partial paraplegia. Those patients, our 8 cases, there's 1 left a permanent Asia B, 1 permanent Asia C, but no cases was left permanent, totally paralyzed. The severe rigid deformity correction, we mainly use 2 forms of the osteotomy, the Ponti and the PBCR, and both are technically challenging. And for VCR, is all demanding, high complications, and operating time is long, and the blood loss is more. The high complications, especially the more neurological complications, are most severe one. You look at the literature from 2011 to 2014. Look at the Lunke, Professor Lunke, he's 147 cases with VCR. The incidence is 27%, is pretty high. From our hospital, in the last 5 years, from 876 cases, we have 14 cases of neurologic incidents. It's 1.5%. There's 5 cases of major, is 0.4%, and there's 9 cases of minor complications. Look at those 5 complications. They have some special. Case 1 is TP, tuberculosis, post-tuberculosis kyphosis, 120 degree, and a complete paraplegia 6 hours post-op. The wake-up test intraoperatively and the neuromonitoring are good, but developed delayed neurologic incidence 6 hours and no recovery for 3 years. It's Asian. And another is kyphoscoliosis revision, severe congenital neurofibromatosis 1, and a severe congenital. Look at this is the cases. The easy or the complication are high. 120 degree, 6 hour post-op neurologic incidence. We think it's overcorrection because when you have a TB, a 30-something years old patient had TB 20 years ago, and when you do too much correction, you need to dissect, and it causing the local blood circulation weak and causing the damage to the spinal cord. And look at this patient. I did the 7th, the 8th revision surgery for the girl. There's a VCR osteocyte translation and causing the partial paraplegia. This is the congenital kyphosis severe with the intraspinal canal cyst. And we did the cyst excision and developed a temporary neurologic deficit. This is the neurofibromatosis 1. It has some tumor inside spinal canal already. We did a canal, decompression, tumor excision, but it developed 24 hours later, developed delayed neurologic deficit. And we did the revision right away, and the patient recovered well. This is a 1-year follow-up. And this is also fibromatosis 1. You see the very severe rigid curve in the higher thoracic curve. It developed temporary complications. Congenital kyphosis with intracanal cyst, and also develop partial paraplegia. So we all try to prevention the neurologic complication for the surgery, but we cannot prevent. The only thing we can do is we know what are the risk factors. From our more than 2,000 cases for the last 14 years, and we know if there is a preoperative neurologic deficit, if it's angular kyphosis, severe one, congenital scoliosis with intraspinal canal abnormality, revision procedure, and also the osteotomy, especially the VCR, those are the risk factors causing the neurological deficits. The neurological deficit, the reason for those complications, there's two main parts. One is mechanical. You misplaced the pedicle screw. You accidentally direct injure the cord. You have a hematoma after surgery. Those are the mechanical, which you can avoid by careful insertion of the pedicle screw. Be careful not touch the cord, and do a thorough hematology to prevent a hematoma after surgery. But this part is very critical. The blood supply to the spinal cord is very important. Avoid overcorrection. Do not lower the blood pressure too much, especially during the osteotomy phase. Be careful not injure the blood vessel. So those are the key points to prevent the neurologic deficit from the blood supply. During the osteotomy, you must careful to prevent the cord damage. For example, the anterior posterior translation of the cord, the temporary rod not fixed enough, not adequate decompression at the osteocyte, close too short, or distract too much. Those are the things you have to keep in mind. Be careful always intraoperatively. So to prevent, you can also do something preoperatively. You need to do a thorough imaging study by the 3D CD reconstruction, MRI, and the 3D printing model to see how the structure was look like. You need to intraoperatively to do a better blood control, the neural monitoring, also, if possible, to do imaging guidance. The robotic, we have one. As some professors say, the robotic is still in the early phase. I think the intraoperative O-arm plus imaging guidance are the best way so far to have an accurate pedicle screw insertion in the cervical, thoracic, in the largely a severe deformed spine. Also, as a surgeon, you need to remember you have to have a safe and a sound surgical techniques. For example, the soft tissue preservation. You are using the ultrasound blade to do osteotomy to prevent the extensive bleeding, to prevent direct injury to the cord. Temporary fixation and the rigid fixation, avoid overcorrection. These are the surgeon we should do. What if happened during the surgery? There's an intraoperative neurologic deficit. Be remember, never think this is you are lucky. There's not happening. Not wait and see, not do a repeat, because the golden time for the spinal cord injury is within 8 hours. So intraoperative, maintain the blood pressure more than 90 millimeter. Do adequate decompression and also adequate circulation. And using some steroids, fixing in situ. Maybe you need an implant removal or take the implant out, check to see if there's any screw misplacement into the spinal column. And postoperatively, also maintain blood pressure, go back to OR as early as possible to decrease the correction force, if possible, to do oxygen therapy as early as possible, because there's no effective medicine at this point, at this stage, to treat spinal cord injury. So severe rigid spine deformity correction, it's a teamwork. It's a teamwork. This is my team. Everyone holding a 3D severe rigid spinal model. The preparation is very important. Evaluation, traction, multidisciplinary construction, because those special severe rigid cases, they all have multiple, maybe they have a skin problem, they have primary function problem. You needed to do a risk analysis before surgery. If the risk is too high, you needed to know when to say no to patient. And very sound education, osteotomy to minimize the risk, and it's a teamwork. So for the severe rigid spine deformity correction, we have 5 research projects in the last 10 years. We published 18 peer-reviewed articles and also have 3 patents for the research. So treating those severe rigid cases, it's depend on your sound technique and knowledge. Also, it depends on your sympathy and love to the patients. This photo are taken from our tour to the Tibet. The scholars kids, look at their smiling face, look at their clear eye. It gives us the courage and the strength to treat those patients. Our hospital is building a new campus in the northeast part of Beijing, and welcome professors to visit us in the near future. And this is all the doctors from my spine team. Thank you so much. Thank you for your attention. Thank you.
Thank you, Professor Yong Hai from China, one of the eminent stars of spinal surgery all over the world. Thank you for this very interesting talk about a very difficult subject by your very informative and very illustrative talk, sir. It makes it very easy for every spinal surgeon to understand such a difficult topic. Thank you so much, sir.
Thank you. It's my honor. Thank you.
Thank you, sir. Our moderator now is the Professor Ashraf Ismail. Professor Ashraf.
Thank you. Thank you. Thank you, Professor Hai. Actually, this is a very informative and meticulous work, and I congratulate you and your team. And I think it is you have built a very strong and high pyramid of your work.
Thank you. Thank you, Professor Ismail.
You use navigation in your work?
We don't have a navigation. We don't have a navigation at this point. We do have a robotic from a Chinese company. The robotic so far we are using actually is only for the not so severe twisted curve, and the severe twisted curve still has a very difficult. So we insert the screw intraoperatively by the pre-planning of the surgery. For some very large curves, we have a 3D model and a 3D the screw template to put on the spine, and there's a guide to put in the screw. But most of the time, we're doing the screw insertion is by the freehand and through the feeling to go through the pedicle screw, the hole, the pedicle, the cancellous bone. So because I'm probably the one of the very few surgeon to do those complex curves in China. So we have a very good team. So, but the screw, accurate of the insertion of screw, we do have a study before that. And several years ago, one of my PhD students, we did a study. We scanned all the patients within a month for the pedicle screw accuracy. Actually, according to the standard, the perfect more than 90% accurate of the screw insertion in the 38 patients within a month is 72%. Another 28% are not accurate, either laterally or superiorly or inferiorly, a breach of the pedicle. There's a 5 screw breach lateral, the inner lateral cortex of the pedicle, but there's only one patient developed a minor symptom. So because of the deformed spine, especially in the apex region, the pedicle are deformed. So it hardly can put the screw accurately like the normal lumbar spine or normal thoracic spine. As long as you not breach the inner cortex of the pedicle too much, it will not cause any problem. Also, in the thoracic, not too low, not too inferior, not hit the nerve root, it should be okay. And sometimes you just insert a screw into the vertebral body and the rib head gap, and then go into the vertebral body. It also has pretty strong fixation force on the vertebral column.
I would like to make a comment here, Dr. Ashraf, please.
Professor Kazam.
Professor Galal Kazem.
I would like
Yes,
to
please.
thank Professor Yong Ho for this very good lecture and talk on this very difficult subject. I'm pleased that you have been using the different techniques of the traction preoperative. In Liverpool, we used to use halopelvic.
I'm sorry, the signal is not so good.
Yeah, Professor Galal.
Professor
Professor
Galal,
Ashraf,
yes.
would you complete, please?
Professor Galal.
Halopelvic traction.
Yes, yes,
Preoperative.
Professor Galal.
Yes, I'm
Yes.
talking. Are you hearing me?
The signal was weak,
Are
sir.
you hearing me?
Yeah, hearing you now, sir.
I'm talking. In Liverpool, we used to use halopelvic traction preoperatively for all cases of scoliosis. And this used to reduce the incident, the amount of correction, final correction we need to do. In the previous lecture on scoliosis in this course, the traction techniques were omitted completely or mentioned just briefly. In this talk by Professor Yong had emphasized the point of the preoperative traction, which reduces the amount of curve to be corrected. I'm pleased to see that you are starting to use the robot for this very difficult type of surgery. In my university, we started a few years ago a protocol for doing a robotic surgery program, but unfortunately, we couldn't complete it for financial reasons. So I would like to thank you very much for this enlightening lecture again. The other point of, in the cases who develop paraplegia or neurological deficit postoperatively, have you been using any cooling system, any cooling coil behind the site of the operation to reduce the edema and the post-operative cathepsins and inflammatory mediators? You have been using prednisolone, as you mentioned. Thank you very much, Professor Yong.
Thank you. We actually for every patient, when we start to do the osteotomy, we will give patient a dose of MP, the steroids, and to prevent anything could happen, because we believe so far the utilizing of MP, it will decrease the inflammatory reaction for the spinal cord, and we don't have other drugs can use. So we just use one dose, 500 milligram or 1 gram for the patient before you are going to do the osteotomy to presumably to have some protection effect, but we don't have a large study to prove that. But we just thought maybe we can have some effect to decrease the inflammatory reaction. Thank you.
Thank you very much, Professor.
Do you have another question, please? Do you get any type of preoperative spinal arteriography for the blood supply of the spine in such difficult cases?
We not every patient. For the patient with angular curve revision cases, the neurofibromatosis cases and the tuberculosis, post-tuberculosis cases had the previous surgery, we will do that. We will do the CT scan to evaluate the big blood vessel or the blood vessel supplied to the apex region, because we had a delayed neurologic deficit. We think it's probably from the blood supply. So, and also from the neurofibromatosis. And we do have incidents in China. That was several years ago. I think it's 10 years ago, one hospital, it has patient during the surgery is a neurofibromatosis revision. During the procedure, the doctor is doing vertebral column resection and then hit the blood vessel, and the patient died in the operating table. So this is give us a warning. Every severe case, you needed to evaluate the blood, the aorta, the big vessels to prevent anything, abnormal there, and you'll be careful intraoperatively.
Thank you for this. Concerning the multiple level VCR, vertebral resection, the multiple level vertebral resection, do you use also in the other levels the Pontus osteotomies?
Yes, I will do a pontioscopy sometime. I will check the movement, the flexibility intraoperatively, use a top clip to clip on the spinal process and try to see if there's any movement above and below. If there's no movement at all, and if the anterior interspace not fixed, not fused, I will do a fasciectomy or pontioscopy to relieve the curve, so it can have a better correction, and you can have some realignment other than the apex level. Because sometimes when you do a VCR, if the above and the below is not released, when you close or when you do the inside to bending, the screw will pull out. But if it has some flexibility, the screw and the rod, they will have some, migration movement to prevent the screw either cutting or either pull out. So sometimes I will do.
Yes. With the 3D templates, you use the whole spine template or the separate vertebral templates?
Separate each level, level, one level by one level. I will do each template. If I will do each level. We'll make 2 sets, because sometimes the bilateral one set you put in on a, sometimes it will the lateral either muscle or some stretch will block your view. So I will put one in, and then maybe another one will cut in half. So you put the half in and then measure the not cut one to make sure the position is still right. So every level one by one in the apex region and make 2 sets for each level.
Yes. Do you have any comparative study between the freehand technique and the using the vertebral 3D templates?
No, we don't have that much, but the 3D templates, actually we using that pretty much in the cervical or cervical thoracic junction, especially in the cervical deformity. And that was very accurate because, you know, we're using in the kids, it's younger than 10 years old or something, teenager for the cervical deformity or thoracic cervical deformity. And actually the accuracy of the pedic school are very good, because we don't have a navigation system, but for that, actually it is very good. It's very good. We just I just did the 5 years old C7 T1 hemivertebra with 60 degree of deformity. I put in the school in the C5, 6, and T2, 3, 4, and the school are very good. And because very small, 5 years ago, I used 3.2 millimeter screw for the cervical.
Yes.
Very good. Just in the pedicle, not in the canal, not in the vertebral artery. So it's good.
This is freehand or by template?
By templates. By templates.
Templates. Yeah.
By
Yes.
templates, of course.
You put in
Freehand for adult is okay, but for kids, and just worry there's any damage to the vertebral artery. That would be a disaster.
Yeah. What about the maximum levels or number of intercostal nerve neurotomies that you can?
I'm sorry.
Yes, for the intercostal nerve tying or sacrification. What is the maximum?
Large amount is unilateral, only one root, with no more than one root.
Yeah.
Because once you get one root out, it has enough space to put in the mesh cage or artificial vertebra. So one root enough. But for if the level you only do one level VCR, you will not need any sacrifice of the nerve root.
No need for more than this. Yes. Thank you, Professor, for your talk. It's very convincing and very meticulous and very in depth. And we hope to visit your center when the COVID-19 will regress at our country. I think it will be.
We are free of COVID-19 now. Yeah.
Okay.
Good.
Thank you so much.
You're all welcome to visit.